So many people are looking to live happier, more stress-free lives. We provide interviews from mental health experts across various fields because we know finding quality information isn't always easy. Let's find more sanity together. On today's episode, Dr. Dennis Zgaljardic talks on neuropsychological evaluations for neurocognitive disorders. Dr. Zgaljardic is a board-certified neuropsychologist and founder of Gulf Coast Neuropsychology, located in the Houston area, where he provides clinical and neuropsychological services with a wide variety of medical diagnostic groups, including traumatic brain injury, stroke, multiple sclerosis, brain tumors, neurodevelopmental disorders, seizures, dementia, memory disorders, and other neurologic-based conditions. He has 14 years of experience working in post-acute brain injury rehabilitation centers, with his most recent position as Director of Neuropsychology and Clinical Programs. He is an adjunct professor in the departments of Neurology and Rehabilitation Sciences at the University of Texas Medical Branch in Galveston, Texas, and past president of the Houston Neuropsychological Society. Beyond this, he has numerous published peer-reviewed articles and book chapters and invited addresses at national and international conferences covering various neuropsychology topics, including brain injury rehabilitation, concussion management, caregiver burden and distress, cognitive rehabilitation, reliability and validity of neuropsychological assessment measures, post-traumatic hypopituitarism, and psychiatric disorders and fatigue post-brain injury. Now on to the interview. Okay, Dennis, good to see you. Welcome to Sanity Podcast.
Thank you. Thanks for having me.
Yeah, no, I appreciate you coming on. So this is the first time that I'm having someone who is more of an assessment-focused psychologist on the podcast, so I'm super excited for this. So you are a neuropsychologist.
Yes. I'm a board-certified neuropsychologist. I know you have a lot of psychologists on your show. A neuropsychologist is someone essentially that sort of is specialized in studying brain behavior relationships. So my background, again, has mostly focused in the neurological populations through the lifespan, whether it's traumatic brain injury, Alzheimer's disease, other neurodegenerative disorders, and also with younger folks, attention deficit and other neurodevelopmental issues.
And if someone on listening is like, well, what does a neuropsychologist actually do? What does the day-to-day of a typical neuropsychologist look like? What type of work are you guys performing?
So, we're very similar to other clinical psychologists. We do assessment, we do therapy, research as well. A lot of my life has been devoted to research. But the assessment, again, is probably different than what a clinical psychological evaluation would mean, where we're looking at cognitive skills. So going through language, attention, processing speed, visual spatial skills, memory, executive functions. So usually the referral that comes to us is this person has some sort of underlying, or we suspect an underlying neurological issue. And outside of, let's rule out what are some of the comorbid factors that could lead to why the person's experiencing memory problems. It's not always a neurological condition. I've had referrals where the neurologist will send the person to me saying, well, I suspect the person has a neurodegenerative disorder like Alzheimer's, but do they really have Alzheimer's? Now, I'm also, given my background, I'm very versed in looking at MRI, CT reports, anything that sort of give me a sense of what is going on in the brain, if anything. And then the evaluation sort of helps split things out. So, for example, I had a case recently where the referral was for a potential or possible Alzheimer's. And then through my clinical interview, which I'm sure any psychologist that listens to this will say is probably one of their best clinical tools, sort of gives you a good sense of what's going on. And in this particular person's case, she had an extensive history of psychiatric issues that she had not really had dealt with in all her life. So by the time she came to me at age 68, she was complaining to a neurologist of memory issues. And the testing, she showed that she had a lot of strengths across the board. So in my opinion, the diagnosis was not Alzheimer's or mild cognitive impairment. It was probably more related to just sort of unresolved psychiatric issues. And my recommendation was primarily treatment focused, which which again, as a neuropsychologist, we do provide treatment. Jason, I've worked several years in traumatic brain injury rehabilitation.
Yep.
So a lot of my day-to-day there was, a lot of it was cognitive rehabilitation, psychotherapy, but primarily assessment as the neuropsychologist there.
And, one thing that neuropsychologists get more training in than clinical psychologists and other specialties are these neurocognitive disorders or neurodevelopmental disorders. So, for example, if somebody came to me with a referral and said, can you do cog testing and tell me if this is a frontal temporal dementia versus Alzheimer's versus, neurocognitive developmental problems later on in a Parkinson's disease, I that's not something that I would be able to do. But you get training in helping trying to diagnose actual neurocog disorders.
Yeah. So again, I mean, when you look at, since you did bring up neurodegenerative disorders like frontotemporal and Alzheimer's, so there's going to be different patterns or in their profiles or their performance that will sort of differentiate one versus the other. So in Alzheimer's case, for example, you'll obviously see memory issues, which is sort of the commonplace with Alzheimer's folks. But you also see a sort of a combination of other language deficits that are typically associated with Alzheimer's, whether it's naming, word finding difficulties, and so on. Also, even on their memory performance, you would typically see a person with Alzheimer's having a much tougher time with encoding information. So if I read them a list of words to remember, they would have a really struggle encoding the information. On the flip side, if I assess someone with Parkinson's, which is more of a subcortical process, there you see a different profile. You may not see as a pronounced memory problem. The problem may not be so much as encoding information, but more of a retrieving information because it has more of an executive aspect to it. So those kind of things where both patients, patient A and B, one Alzheimer's, one Parkinson's, may both have memory problems, it's sort of helping to differentiate their two profiles to help neurologists and other treating doctors with their diagnosis and their treatment plan.
Yeah. And you said something really cool here, which was cortical and subcortical. And just for people that might not know what that means, when you look at the brain, like, in movies or images and all the, wrinkly parts on the top of the head, that's the cortical part. That's the top part. Then the subcortical is, say that you kind of could peel it off like an orange and it'd be a thick peel. There's a whole lower part of the brain, which have different functions, with the top cortical functioning. And well, maybe you should tell us. So what's happening more in the cortical level than in the subcortical level?
Well, the cortical level, you're going to find all of your sort of focal main compartments in terms of what it is that we do, whether it's language or visual spatial or vision and so on. And then the subcortical, the white matter, is really sort of the messenger, so to speak. They're propagating the information. So you have your gray matter, the cortical matter on top. And then if you were to look at a coronal or a sagittal view of the brain, you would see all this white matter. And the white matter just sort of comes all the way down as you go towards your spinal cord and sort of transverses down that way to send out the signals. So again, if you look at someone who has a stroke, you would see there was typically be more of a cortical type focal injury. So the person may have a language issue like aphasia, where in a traumatic brain injury, you may have someone that has diffuse axonal injury, which is typically more of a subcortical damage. And the person may still have preserved language and other skills, but maybe their processing speed is slower than it was before the injury. So it's a sort of different way to look at things.
Mm-hmm. And higher order reasoning would be in more, and not that it's not all connected, but the higher order reasoning would be in the cortical, front cortical area.
Yes.
And of course, movement goes through the whole system, but some more of the planning part of movement, would that be more cortical? And then the subcortical.
So your primary motor cortex and your primary sensory cortex, as it says, are the cortical parts. So if you have a stroke in the primary motor cortex, you're going to be hemiparetic or have lack of motion on the other opposite side of the body. I mean, that's just going to knock that out. As you move more interiorly, if we're just talking about motor, you'll have different aspects of your motor abilities impaired. So if it's impaired on the motor strip, you're going to have lack of motion in, let's say if the injury is on this side, you'll have lack of motion or paresis on the left side. If it's more of an anterior injury, you may have more difficulties, not so much with motor strength, but maybe motor coordination, motor timing, how you plan the motion. We had one case long ago. The person had a very, very anterior communicating artery aneurysm. and that affected what they call the anterior callosum, the white matter that connects to sort of the frontal parts of the brain there. And the person had what they call alien hand syndrome. So they had fine motor movement, but sometimes the one side of the brain was telling the hand to do something that was out of that person's control. So they couldn't really tell. So they would usually like try to grab their shirt, even though that was not their intention. Okay, they didn't do anything like malicious or bad with that hand, but it was just like this jerky movement that the person didn't have control of. So that is still part of the motor track. But again, as you go forward, there's a increasing layers of those abilities are getting built upon. So it goes from your basic motor skill, moving your hand. Think of like binary, on and off, zeros and ones. As you go further, that becomes more complicated in terms of skilled movement, how you're reaching out to movement into space, grabbing things and motion, intention, all that kind of stuff.
So going into the neuropsych eval specifically, what are the different, you said some of them before, but what are the different things that you will look in the clinical eval? For example, you said a good clinical interview. And what are the other components of a neuropsych eval? Yeah,
first and foremost is the clinical interview. I want to make sure I'm getting all information. And as again, I'm sure some of your listeners, professionals, know that you don't always get the medical records that you want to get. So sometimes having, and also especially in most cases, you want to have a family member there to give you as much background information as possible, because they're, especially in the elderly population, the dementia type cases, it's going to be the spouse or sibling, offspring that's going to sort of sit there and tell you like, yeah, mom or dad, or they're doing this, while the patient themselves is sort of denying it. So that's always important to have someone in there with you if possible. With regards to the domains, I'll very brief little story. When I was on an internship, I think it was Heilman and Ballenstein, the clinical neuropsych books that I've been trained on. I think it was Heilman came to do a didactic on my internship, and they brought in a patient. He didn't do any neuropsych testing, but he just simply asked the person questions. But he did it in a way where if you were trained and you listened to his questions, you almost knew he was going from anterior to posterior in terms of how he's asking the questions about what the person experiences. And that's sort of the same thing that goes on with the domains that we assess. We're not assessing language just for the sake of assessing language. We know that there's parts of the brain that are specific for language. We know there are parts of the brain specific for visual spatial skills, executive skills, and so on. So the neuropsych eval is sort of just mirroring that. So after the interview, I'll want to address some aspect of sensory motor. Now, typically the neurologist, if I do have records, will have done a complete neuro exam, and I'll get a sense of cranial nerves and paresis and all that kind of stuff. But sometimes I like to see it for myself. Sometimes neurologists may not assess for other things like visual spatial neglect, where a person after an injury, a stroke or traumatic brain injury, may have a difficult time attending to stuff on the left side. So I want to assess for that specifically. I want to also look at fine motor skills, because sometimes not just if I see it first, but I want to make sure that these things are set in place. So if it's going to interfere with their performance, if I'm doing, for example, a visual processing speed task, like on the waist, like the symbol search or a coding, if they have a fine motor issue, that's going to impact their performance. Is that really because of their processing speed skills or because they have a fine motor issue? So I do that just to sort of get a sense of where they are physically and sensory. Then I'll go into language, sort of just to get a basic sense of their naming skills, word finding, a basic comprehension. Okay, I'm not having them listen to paragraphs of information and so on, but I want to get a basic level. Visual spatial skills, again. So again, I'm sorry, I should have prefaced. Language, we know that most people have language in their dominant hemisphere. So if there's an injury there, you're going to expect to see some language problems like aphasia and so on. On the other side, the non-dominant hemisphere, you're going to see more visual constructional, visual spatial skills. There's a whole theory of we have our what and our where pathways. Our what pathway helps us develop what an object is that we see. So when the visual spatial information comes in, our brain sort of breaks it down and we get a sense of what it is. We're able to identify it. And the where pathway, our visual spatial skills allow us to determine where things are in space. So we're able to reach out for our cup of coffee without overshooting and doing all those kind of basic things.
And so what do you mean by dominant and non-dominant side?
So, okay, yeah, I'm sorry. So the dominant hemisphere is is where language is, right? Mm-hmm. So I would say the majority of people who are right-handed, about 95% of people who are right-handed, will have language on their left side. So if you have, God forbid, have a stroke or injury on the left side, there's a good chance you're going to have a language problem. The non-dominant hemisphere is the side that does not have language. So that would be typically the visual spatial aspect of our brains. And for most people, it's going to be the right side of the brain that is the non-dominant hemisphere. Okay. So again, dominance is where language is, essentially. And then also, so after I get a good, and again, if you can imagine, language and visual spatial skills are really the more basic domains I'm assessing. Once those are cleared, then I go on to higher order. So attention processing, executive skills. And as I'm sure a lot of your listeners probably know who are in the field or have assessed executive skills before, EF, executive functions. Executive skills is not a unitary function. It's hard to pick one executive test and say this is covering the person's executive skills. Especially in the traumatic brain injury world, I've had folks that aced a lot of the executive tests, but they go on to do a lot of inappropriate behaviors that sort of fall outside the norms that what we would consider appropriate. So clearly that is also an executive issue that we have to address. Yeah. So it doesn't always transfer to paper and pencil testing.
And I might be over speaking with my opinion here with executive functioning testing, but we have very good executive functioning tests for specific domains of executive functioning, but we don't have executive functioning tests for the whole range of executive functioning. I think that's what you're talking about there. So we could see if someone is having a hard time changing rules or maintaining an idea or, things like that. But we might not be so good at measuring social cognition or doing appropriate social behavior with reasoning or planning out and stuff like that. So people really can ace executive functioning on the test, but have very serious executive functioning problems.
Yes. Yeah. And that really goes right back to my clinical interview. That's where I want to get that information, because I've had individuals with severe traumatic brain injuries who have made an awesome recovery and are functioning very well in a more structured setting. But I would still be very concerned of allowing that person to go back out into the community to do A, B, C, or D because of their poor social cognition or inappropriate behaviors that you're not going to see on paper and pencil testing. So those are the biggest concerns. And I've told people, I think I probably told you when you were training with me over here in Texas, the person that concerned me the most in terms of functional outcomes was not so much the person that maybe had a stroke with a hemiparesis on one side, maybe some language issues. It was the person with more of a frontal injury who had complete ability to function and move and speak, but may not have the wherewithal to decide what is appropriate in the community. And they're the ones that are more prone to making poor decisions, poor judgment, and God forbid, sometimes get themselves into other hairy situations. So that's something you're not going to get on any kind of paper and pencil neuropsych test.
What was that famous case where the guy, I think he was working on railroads and it was like AF or something where do you know what I'm talking about?
Phineas Gage.
Phineas Gage. Yeah, that's what it is. Yeah.
No, I definitely recommend to your readers, if they want to get a good sense of probably one of the most classic neuropsych cases, look up Phineas Gage. Very briefly, he was a gentleman back in the 1850s working on the railroad in Vermont. And he was tapping down what they did back then to dynamite sides of the mountain for the railroad. He had gunpowder or whatever down in the hole, and his iron spike hit a rock that caused a spark. And the iron spike, this 4-foot, very thick, iron, just sort of got him here and
so
outside the top of his head,
through the chin, out the top of his head.
And he survived for I think another 11, 12 years until one day he had this horrible seizure and passed. But what was, you have to remember, this was like Victorian times. This is, back in the 1850s. And this was your average Joe who behaviorally just started acting super inappropriate, was obviously using vulgarity and his behaviors generally that was just not, accepted by society at the time. But that, again, I advise your readers to look him up. He's an interesting case study for sure.
Yeah. And this is just jumping in the middle, but what was it? Oliver Sacks, the man who mistook his wife for a coat rack. Like that's another hat rack or something. Hat rack. I should probably know the name of this for recommending it, but that's another really interesting book about neurocognitive disorders and how it plays out. I'll put a link of the actual exact name, but that's definitely the author.
Yes, it is. Yeah, that's
been a while since
a good story for sure.
Okay, so you had mentioned some areas that you measure. So we also have like memory, IQ.
I didn't go into memory much. But yeah, no. Memory is usually, and again, I may have told you this when you were with me in Texas. It's going to be the biggest complaint. So 95% of all my patients, whether it's traumatic brain injury, stroke, neurodegenerative, that's going to be their big complaint, memory. And a lot of times it may not be memory. It could be something else. It could be an executive problem. It could be an intentional issue. I tell a lot of my patients, well, if you're not attending to something, how are you remembering? So a lot of our the brain injured folks that I worked with in my years, usually it was an intentional problem. It was not necessarily a memory problem per se. A lot of times people, I think a lot of maybe your listeners or the general public just think, well, oh, he has a memory problem. He must have Alzheimer's. He must have some sort of dementia. That's not the case. A lot of cases you want to look at to make sure that it's not attention. It's not their ability to process the information and to acquire the information. If you've ever seen an Alzheimer's patient in later stages, it's very clear their memory profile. That's a very sort of flat learning curve, and even their recognition of information is poor. Or like earlier I mentioned about the persons with Parkinson's, where they may also have a sort of a very low or slow learning curve, but they typically can recognize information after presented to them. So there's a difference between encoding and retrieval. And that's where some of the memory tests that I select and most other neuropsychologists use help differentiate those issues.
So, and I'll go into some of these regions a little bit more with you, just to break them down, the big ones. But before we get there, just to sum up. So when someone goes for a neuropsych evaluation, a lot of times people just think, well, you're just going to test my dad, or you're going to test me or test my kid, and then we're going to have some numbers and that's going to be great. It's way more complex than that. It's an entire clinical interview, getting their background, change in functioning. How has their behavior been changing over time versus even just recently? Trying to get reported symptoms versus getting the symptoms from the testing, looking at collateral information, like it might be imaging, it might be medical records, and it might not even just be neuropsych medical records. It could be, if someone has a thyroid problem or something hormonal, or they recover, they had cancer before, or whatever it might be, having all that medical information, observing them, seeing what their behaviors are during the testing. Can they focus? Are they looking away? Are they saying inappropriate things? Are they talking too much, talking too little, expressing emotion? Going through all the testing, then taking all of that testing and all the other information, putting it all together to figure out what's going on with the person. And one thing that you mentioned several times, which I think is critically important to the testing, is that all of these different areas have different layers of functionings in different parts of it. And so, but since the system is all interconnected, one broken area in a chain could mess up the entire chain. And I'll give an example of that. So you need to look at all the different parts in order to figure out what's wrong. So you were talking about learning a lot. So with learning, first you need to have the attention to look at what you're learning. Then you need to be able to pull it into the shorter term memory and have it there. Then you need to be able to convert it and encode it and store it. And then after you store it, you have to be able to retrieve it. And somebody might say, I have a memory problem, but their memory system might be intact, but it's actually because they don't have the appropriate attention. They're unable to get that information in, but had they had that attention, the rest of it's working okay. Or the person has the intention and it's not being encoded in, so then it never gets stored so they could retrieve it. So the systems are far more complex than what maybe anybody might assume. Or maybe not assume. Maybe they think it's definitely that complex. And we were taught that if you read on Alan Badley, looking at both working memory, you summarized it pretty perfectly there in terms of looking at the verbal working memory as well as visual spatial sketchpad and visual spatial working memory. So really that whole process, it was all sort of laid out by someone like Alan Badley. And then we sort of adopted that into neuropsychology as we do our assessment. You have to remember, while neuropsychology itself has been around for a good 40 plus years as a clinical sort of approach. We're basing it all on the studies of people from the past, Gerstmann and all these other folks that sort of built up their knowledge base of the brain in terms of classic neurology that sort of transferred into
neuropsychology and how we assess it. So again, cases like Phineas Gage and all those folks that we were able to extrapolate that information from and say, okay, well, how do we see that in a snapshot when we're seeing our patient in our testing room? So those tests were eventually developed over time, going back to probably the 40s and 50s, and then just getting sort of built upon and improved over time.
Mm-hmm. And so when we do these testings, you have to rule out simple problems or more base problems. And then if those are okay, then you assume it's something more up the chain. Like Definitely. When you were talking about, like if somebody has a motor problem and you're asking them to do something with drawing to test something, you can't assume that there's something with that system if they're unable to draw because there's a motor issue.
Exactly. I always start with the sensory motor is my first. I want to just get a general sense of what's going on. Because again, like I mentioned earlier with that visual neglect, and I know maybe for some of your listeners, maybe they don't know what neglect syndrome is. It's typically an injury that resulting from the non-dominant hemisphere, which prevents an individual to attend to their left side. It sounds, and I'm not saying it happens in all cases of right-sided damage, but it's a very, very odd phenomenon, especially for the patient. People think, well, they're not seeing that way or they're not hearing that way. They're not attending to that way.
Yeah.
So if I have a patient that comes to me with a right-sided injury and I didn't assess for neglect first, and then I'm doing this testing and all of a sudden they're not focusing on the left side of their page or something, I'm like, what's going on here? And so you want to get the basics first and then build from there. And there are times I'll modify my battery in the middle of the evaluation. If I feel a person is struggling on the basics, why would I then go give them a very complex executive functioning test when I know that they're not going to be able to do that or do that really well? So it's a combination of I have a plan before they come in terms of what kind of tests I want to give based upon my knowledge. Hopefully I have enough of it before they step in from the medical records. And then I sort of plan it out as it goes. But again, like you said, a comprehensive neuropsychiaval can last somewhere between 4 to 6 hours. But that includes everything you mentioned earlier. I'm not going to go through it again because you want to get that picture. It's hard, as with any other clinician, to make that decision in such a short period of time. If that's your one time with them in your office to make that determination, you want to make sure it's as accurate as possible. Because again, especially in neuropsychology, what the decision you're making, and having worked in the rehab world for most of my career, that decision is going to then sort of dictate what their treatment course is. So I want to make sure that my diagnosis is putting them on as correct treatment course as possible so they're getting the best help. Because as you know, having done some work with me, you know that folks with traumatic brain injury, stroke, they tend to improve. That's the goal. So you want to make sure they get on the right treatment path after the diagnosis.
And then also, I mean, part of the nitty gritty here that we keep talking about is that all these domains have little smaller subsections to them. So it's not just language. Language underneath it has all these little different subsects. So you need to measure, multiple parts of a single cognitive area in order to get an understanding of it. So I just want to go through some of these areas just so people know what we're talking about. Sure. I think language is pretty pretty self-explanatory, but let's go through some of the areas of language that you look like aphasia, naming things. I don't think people often think about how such a basic function of saying this is a cup, this is a microphone, really could get damaged by having a stroke or a brain injury.
Right. So let's break it down even further. And again, let's use our cortex as the map. So again, let's do the dominant hemisphere, the left hemisphere. You have anterior and posterior regions for language. So in the anterior region, you would expect more expressive language dysfunction after a stroke or injury. So like you mentioned, so if this is more of a frontal injury on the left side, I would be expected to have more difficulty with naming, general speech. The person will be aphasic. They may not be able to say things. Of course, your listeners can look up Broca, a famous neurologist from the 1800s who had his famous patient that they called Tan, because that's the only word he would generate was Tan. That's all he was able to say after a stroke. So again, you'll have more of an expressive language aphasia. More posterior injuries, you'll have more of a receptive language aphasia. The person can have what they call jargon aphasia. They'll speak fluently, but it'll be gibberish usually. It's maybe more nonsensical, not on target, not on topic, but because their comprehension is impaired. So if I'm saying something to you, and God forbid, Jason, you had a receptive aphasia, you may not be comprehending what I'm really asking you or telling you, and your brain is going to shoot something out based on what you thought or the brain thought and interpreted or deciphered. So the person, so you'll have on one sense the more non-fluent aphasia in the frontal aspect of the brain, or the anterior, and the more fluent aphasia and the more posterior if there was damage in those areas.
All right, so we have any other areas of language?
Again, there are so many different types of aphasia too. So you have more in the frontal part of the brain, like you said, since it's more the expressive aphasia, you can have the transcortical motor aphasia, Broca's aphasia, or it all depends on where it is. You'll have different symptoms related to it. There's also I'm blanking on the name now, where the person's ability to repeat information or mimic is impaired, or conductional aphasia, excuse me. So you have different parts of the brain that could be impaired, affected differently based on where the stroke was and how the language is sort of presented. But again, the more expressive aphasics, they tend, from my experience, they tend to improve or make improvements more readily than some of the receptive language aphasics. It's just it's probably just more of the complex system, but the recovery for the expressive aphasics tend to be a little bit better. And that's where speech pathologists and all these other great therapists come into play to sort of help out.
Yeah, and we can see the different areas of expressive and receptive with children, where they could understand sooner than they could speak. If you just look at general overall development, sure. Yeah. Okay. Visual spatial. What does that even mean? Or perceptual reasoning, visual spatial. What does that even mean, and why is it important?
Well, again, our world for people who have vision, you're taking information just like you are with your ears when you're listening to language, since we are immersed in language in this world. So in terms of visual spatial, we want to make sure that we're navigating our environment correctly. We're not bumping into things, even though some of us, like myself, it can be clumsy. We want to make sure that we're navigating the environment, we're attending to the environment well. So when it comes to the visual spatial domain where I assess, again, most of my patients will not have severe visual spatial problems, except for those folks who may be traumatic brain injury or stroke and some other neurodegenerative processes. I want to look at visual perception. So sometimes I'll use a very basic visual form discrimination task, just sort of, does this shape and these choices down below, or which one is the same as this one? I readily use like matrix reasoning from the WACE. Again, a little more abstract reasoning in that regard. And then construction, just any kind of construction task, block design from the WACE being an example, but anything just to see how they're not only can they discern, certain shapes and how they sort of interlay over each other and so on. But also to just sort of look at their planning of it as well. Is there approach to a design piecemeal, or is there some decent organization to it? So again, another thing I want to mention to you and your listeners is these tests are not, again, just sort of compartmentalized by themselves. So when I'm looking at visual construction skills, I really am still looking at executive skills, planning and organization. So again, even though there are separate domains like you initially described, they're really they're interrelated in so many ways. I don't just look at it as, they are impaired on a visual construction test, and all their executive skills are also impaired. Could those two be related? They probably are.
Yeah, because a single test, because it's all connected, hits multiple domains.
Yeah, and that's a thing that, when you explain to patients, when I do provide a feedback session, is I try not to, of course, explain one test on its own. But you have to, any good neuropsychologist will explain and look at the entire profile. What's the big picture? What does everything look like? Remember. And again, you and I could also probably discuss at some point, if you'd like, about symptom validity, about whether or not someone's putting forth good effort on testing. And it doesn't necessarily mean they're intentionally wanting to not put good effort. It could be they're not having a good day that day. They're not feeling well or something. Especially if you're working in a neurologic population, they may have medical issues that they're not feeling well. So sometimes these other symptom validity tests, which unless you wanted me to, I can get into more detail, just sort of help determine what is that person's level of effort at this moment?
Mm-hmm.
So we want to look at that as well. That's very important when you look at the broad range of neuropsychological testing, because again, remember, a neuropsychiaval is a snapshot. Unlike rehabilitation, where you see the person progress day in and day out as they're getting therapies and so on, the neuropsychiaval is a snapshot. This is what they're doing that day. But I want to also make sure, were they putting their best foot forward that day when I did the evaluation?
Yeah. So effort in the testing is a prerequisite into knowing what their full ability is. But effort someone could be intentionally not wanting to do a good effort, but a lot of times it's like what you said, it's not intentional. They might have gotten to a fight with somebody. They might not have slept the night before. They might have been put on a new medication, which is making them groggy. And so they're just not putting forth and showing their true ability. And those lower scores are not going to be accurate of some sort of actual dysfunction.
Yeah, there's a whole different topic of forensic neuropsychology, which we don't have to get into today. But that would be a completely, exactly.
Yeah. So we would talk about attention and processing speed. Just briefly, what is attention and what is processing speed?
Well, attention again, and this is definitely the area which I think is mostly impaired or affected in a lot of neurologic populations. Because again, like I said earlier, they'll always complain about memory, but if you look further, it's usually attention processing. So within attention, you have sustained attention, divided attention, gross attention. If you have someone who's severely impaired, you're looking at the basic. You're looking at gross attentional ability. Are they able to track? Are they able to stay alert? Are they easily arousable? From that, you could then increase to some more divided attention. Can they attend to two objects or multiple things in the environment at a given time? Sustained attention, can they stay focused on a task for a long period of time without getting easily distracted? And again, that could probably bring us into the whole realm of attention deficit disorder and so on. Then processing speed is how quickly our mind can sort of take in information, manipulate it, and spit it back out. Again, like we mentioned in the very beginning, when you have someone who may have more of a subcortical process or injury, they may have lower or slower processing speed because, again, those connections are not as readily available. When we think about this diffuse axonal injury, that's probably a term I hear on the news a lot. That's just sort of spread around. Think about the wire in your wall, right? The copper wire, and it's got a rubber sheath around it, or a tubing, or whatever you want to call it. That helps keep the electrical message within that copper wire. It's trying not to escape. Well, our brain, our neurons have sort of the same thing. We have the axon, which is the same thing as that wire, and we have a myelin sheath that wraps around it that helps prevent propagation of electrical information outside the neuron, tries to help keep it on that path as best as possible. So in a diffuse axonal injury, because of the nature of the injury and the way the brain is contorted during an accident, that myelin sheath can be torn off. And then all of a sudden now the neuron is still alive. It's not a dead neuron, but it's not effectively transmitting information. So the information now, as you can imagine, is slower. Just like if I had a copper wire that was not covered, it may not propagate the electrical information as readily as maybe like fiber optics or something like that.
Yeah, definitely. And then we hit on executive functioning, but and we said that it was complex, and we kind of left it there. What is executive functioning, and why is it so complex?
Well, again, as humans, because of the nature of our frontal lobes and what we were able to sort of develop over time, and the complex aspects of what we can do, and really, in terms of the frontal lobe, it is the seat of our soul. It is who we are as individuals, and you could look back at a book called Descartes' Error. Looking at where they thought that our soul was in our pineal gland. It was that little tiny gland in our brain. But really, neurologists over the years determined, and also neuropsychologists, that our soul is really set in our frontal lobe. And if there is damage to the frontal lobe, that's usually where you'll see personality changes in individuals, where you'll have the loved ones say, Johnny is just not the same person he was after that traumatic brain injury, and he had damage to his frontal lobe. So you have different parts of the frontal lobe. Just to give you a breakdown briefly, you have the dorsolateral parts of the frontal lobe, you have the orbital frontal cortex, and you have the medial frontal cortex. So the dorsolateral has a lot to do more with memory, organization, planning, things that you would typically you'd be more readily able to assess on a neuropsych test. So again, Wisconsin card sorting test, some other types of these executive tasks. Orbital frontal tasks or orbital frontal lobe has a lot to do with just sort of how we do behave in the world, or sometimes compulsions. I remember reading a case study once where there was I think he was some sort of cardiologist or oncologist who had a horrible tumor in the orbital frontal cortex. And once they removed the tumor, unfortunately, some cortex came with it. And all of a sudden, this was a very sort of well-minded, astute individual who is now gambling away his entire all his money and savings, not having a sense of consequence, if you understand that.
Yeah.
Our medial frontal lobe has a lot to do with our initiation, motivation, our sort of that oomph, so to speak. So you can imagine the medial frontal and the orbital frontal cortex, that's hard to sort of test on paper.
Yes.
Okay. Now, that's again where the clinical interview is key. So I'm not trying to say that you cannot assess or gather information on executive dysfunction. But again, I think the neuropsychologist is very well equipped to ask those specific questions, to really knowing where a possible injury or a tumor or whatnot is located, to find out this is why that person's behaving that way. And usually the first statement from a loved one is, Johnny's not acting the same way he used to. Something happened. He was this church-going, good-natured, Catholic boy, and now he's cussing up a storm and doing all these horrible things, and we don't know why. And unfortunately, it's the injury.
And in there you talked about impulse control, social functioning, and then also aspects of emotion regulation that we would find in executive functioning.
Yeah, you'll have a lot more aggressive tendencies, impulse behaviors, like you mentioned. There's tons of studies looking at orbital frontal cortex damage and gambling tasks. It's not so much that the person has the impulse to gamble, but they will usually make the poor decisions. They're looking at the short-term goal, not the long-term goal. So when they're doing these gambling tasks, they're betting for the immediate gratification. They're not betting for the long game, thinking that, wow, if I play my cards right, I could really bank up a nice sizable pot here, versus I'm winning right now, so I'm going to do it right now. So I usually explain it as like the path of least resistance. The person is sort of looking for that immediate gratification because they're not looking at the big picture. And that's very much in sync with these executive function type deficits.
And then memory. And as you said, everybody thinks about their memory, talks about their memory, is worried about their memory. And we went through the different areas, but what are the different types of memory?
Different types of memory?
Yeah, like visual, verbal, and sort of like brain. Like what do you actually assess when you're doing memory testing?
Right. So if you go back to like Adam Badley and some of those other concepts, you have the working memory. So I want to look at short-term work. I want to look at working memory skills. So sometimes, again, for those of your listeners who may be familiar with the WAIS, digit span, arithmetic, something that where the information is just being manipulated at that moment. They're not looking for long-term. Then, of course, when it gets into long-term memory, that's more semantic knowledge. But semantic knowledge, you're not going to really be assessing on a lot of these tests, because semantic knowledge is going to be factual information. So if you think of like the information subtest from the WAIS, where, what is the capital of Italy, that kind of stuff. These are things that we learned long ago. While we may assess that on an intellectual test, I'm not going to assess that for memory on a memory test in a neuropsychiaval. Episodic memory, that's memory for things that we have developed in our past. So do you remember where you were for your 8-year-old birthday? That's more of an episodic memory. What we're looking at on neuropsych tests is rote memory, visual spatial memory, like you mentioned, sometimes contextual memory, story memory. We want to give people information that they would not have any kind of introduction to prior. So reading a list of words that they never heard of, they were never read to before by someone, a story that they may never have heard before, looking at designs and presenting the designs and then asking them to learn those designs, and usually over trials. We're not just doing a flash memory where they're asked to look at this. Okay, now remember for the next half an hour. We want to make sure they're learning it. So a lot of the tests are geared to have 3 trials, 5 trials of presenting the information to make sure they learn it. And then Also, within most memory tests, you want to look at encoding, retention, and retrieval. So when you're encoding information, if I read you a list of words, you are now actively trying to encode that information. Now, based upon your abilities and your background, you may try to be efficient in how you learn. You may figure, well, wow, those words that Dennis read me, I could put them in certain categories, and that may help me remember them better. If you have an executive function deficit, you may not even think of or consider doing that in that organized fashion, right? Then the retention, over a 20 and 30 minute delay period, are you holding on to that information? And then retrieval, especially like in a recognition trial, I'll say to you, okay, Jason, did I say the word book? Did I say that word to you earlier? And then the person will just say sort of a yes or no. And that will determine on how well you encoded the information, even if you may not have retrieved it when I ask you just to give me the list back without any kind of cues. So the information may have gotten in, but you're having a tough time pulling it out. Okay.
Mm-hmm. And why even bother measuring like rote memory, which is going to be like repeating a list over and over, like what we used to do with index cards, versus like contextual memory, which might be more like reading out of a textbook or hearing a story, or even the visual memory with rote content. Like, why do we even need to look at all that?
Well, my preference is always to look more at rote memory. The contextual memory is good, especially if you want to get a sense of if that will help the person remember things better, if it's more in a context or in a story. The rote memory, again, you're just sort of giving a person a very bare bones information, again, stuff they would not have been expected to be remembering on that particular day. Because in a lot of cases, I want to look at anterograde memory. I want to look at that person's ability to lay down new information and learn it. Again, I'm always giving this to you in the context of especially the populations I've worked with before, mostly in traumatic brain injury and stroke. I want to see if the person can learn the new information versus retrograde memory, which I said earlier was remembering things from your past, your personal past, what you did at your job. A lot of our patients, they may be able to say, well, I'm doing just fine. I can remember exactly what I did at my work. But they may not be able to remember what they had done in therapy, 2 hours ago, or who they met with. So that would be the difference between retrograde and anterograde memory. So the tests that I administer are looking really at anterograde memory.
So me and everybody else that's probably listening is trying to remember what we did on our 8-year-old birthday, which I absolutely can't do. Like, can you remember that?
Only probably through pictures that I probably saw at my mom's house, but it's been years ago because she lives somewhere else.
Should I be worried that I can't remember my 8-year?
No.
Totally
it'll probably pop back to you when you see something.
Yeah, I'm sure my mom has a picture of it somewhere. We mentioned academic ability just briefly. What is it and why do we assess it?
Yeah, I don't readily assess academics in particular populations. So in my traumatic brain injury, my stroke populations, I'm not giving them tests of spelling, reading, or mathematics. Sometimes single word reading, which is important if you want to, especially in the neurologic populations, if you want to gauge premorbid abilities. Usually if someone does sustain a head injury or stroke, and as long as they're not aphasic, their reading skills are typically pretty good, or they're going to be consistent with what they were before their injury. So that can give us a measure of where they were before. Because remember, if I'm assessing someone that may have had, let's say, a neurodevelopment disorder pre-injury, and then they had an injury, remember, as a neuropsychologist, I'm comparing their scores to a normative sample. So I want to get a general idea of where they were before. So that's why the clinical interview is important. So if I understand that the person, let's say, was high school diploma, they had a certain job, then I can say, okay, I could pretty much, and there's no history of a learning disorder, I can gauge that person's probably around the average range and their reading level is about average. But outside of that, I don't typically give tests of academics, in the exception of if we're looking at more like attention deficit individuals where you want to rule out the possibility of how a learning disorder could be impacting the person's attention going forward. So in those cases, I'll use sometimes a screening academic battery or a more comprehensive one, depending on the situation.
Mm-hmm. And a big area where we use this for learning disabilities, to check on if their academic ability is matching up with what we would assume they could do cognitively. And I mean, we moved away from that discrepancy model, not completely, but But that would be one big area of looking at academic functioning.
Well, and you'll get a lot of folks. I tested an 18-year-old not too long last week, where his memory skills were stellar. He was able to remember a lot of information, but on some academic testing, he was doing very poor. So there is that separation. Now, however, though, during my clinical interview, he would tell me how he does really try to improve his academics by using compensatory strategies. So in his case, having a strong memory benefited him greatly. But a lot of times, especially these younger individuals, they reach that point where the material, let's say at school or at work, becomes so overwhelming that it overwhelms their memory ability, that then the learning issues kick in and they struggle. So that's why, looking at academics in a lot of those types of cases is important, because you want to get a sense of where they are, as well as with intellectual skills. I mean, again, not a testing, or when I have a brain injured folk, I'm not really caring so much what their IQ is. That's not important to me, because I'm looking at function, not overall premorbid skills per se. But again, in the population, like attention deficit and so on, I want to be able to rule out other potential neurodevelopmental issues to see is the potential problems that they're dealing with, is that consistent with the diagnosis of attention deficit disorder, or is it learning disability, or is there intellectual problems going on? So you want to give those tests to rule those out.
Yeah, and IQ is actually next on my list here. Usually when people think about testing, IQ is the first thing that pops up, and it's actually one of the last things we're talking about. Mm-hmm. But what is IQ, and what does the testing look like? For what are we looking for in IQ testing?
Well, so we're just looking at a person's general overall functioning, just to get a sense of what their overall skills are. And again, of course, it is broken down into verbal and perceptual abilities, which you would expect given our brain and our different hemispheres and what they control. So you can have individuals that will have strong verbal intellectual skills and maybe not so great perceptual intellectual ability. Overall, then we get that that sort of that one IQ number, which a lot of people sort of jump on as to what their intelligence is. But it really is looking at a whole different factors. So if you look at the intelligence testing, again, obviously the most common one out there, you're looking at visual construction, you're looking at working memory ability, you're looking at processing speed, verbal information, but you're also looking at the semantic knowledge and some aspects of executive skills even. When they're asking you for like on the similarities test, you're sort of verbal abstraction or matrix reasoning. You're looking at nonverbal visual abstraction. So it's trying to get a sense of overall all these functions, and it's coming with some index. This your average intelligence, your high average intelligence. But I think you probably would also have seen in some of your patients that doesn't always equate to their functional ability. So we have to be careful that intellect, cognition, and function really do have to be seen separately, and academics too. So I try not to weigh too much on an intellectual test unless the person has a background or history of neurodevelopmental issues where you want to get a gauge of where they are on their intellect. So I try not to hang my hat on that too much.
Yeah, and we measure a very specific IQ. Like, there's so many different IQs. Like having like a physical IQ is going to be someone in the NFL, or like me, I can't dribble a basketball. My motor IQ is just so low. Probably not that low, but but there's people that have, or people that are great musicians, right? That is a total different intelligence than the intelligence that we're looking at, which is really how well can someone process information and make connections and make abstractions and learn, more complex information and different aspects of that.
Right. Now, again, a lot of the tests that are in some of the intellectual tests that are out there, I use my neuropsych battery, but I don't use them all my goal is not to get an IQ index. There are certain components of the intellectual test that, that's a good visual construction test, or that's a good working memory test. So I incorporate that into my Neuropsychiaval. But it doesn't mean my goal is to gauge an intellectual index score to see what that is.
So we gave people a lot of information about neuropsych, what you look at, why you look at it, how you look at it, the different domains, different populations. Is there a specific case that you could think of where you can illustrate how a neuropsych evaluation really helped this person figure out what issue was going on and sort of point them in the right direction for what to do afterwards.
Wow. Yeah, no, I mean, there's so many years working in brain injury rehab, so many lives that were, that came across my path and difficulty. But again, the one that stands out the most, and again, the reason it came up to my mind so quickly is I tell this story to a lot of people, and it is public knowledge. This gentleman actually went out to write a small book about his experience. He was a British fellow, was living out in West Texas at the time of his injury. This is going back, I think, 2007. And he had this posterior parietal lobe stroke. Again, young man at the time, I think he was probably mid 40s or something. And I'll never forget, there's this odd thing about, well, not odd, I shouldn't say that. Interesting thing about him. He was like ranked the ninth best dart player in the world. And that will always stick in my head. I don't know why. So he had this really interesting stroke, and I was starting to do my neuropsychiaval with him at the facility, and this was a gentleman who had pre-morbid, a graduate school background. He was working as an IT engineer at the time of his stroke, so clearly there was no question he was of at least average intelligence, right? There was no history of other neurological disease or anything else, and I got a lot of that information from his wife. And I'm doing some testing, and he's struggling on some really basic things, even though speech is fine, comprehension, no problem. And I remember I asked him to just write a sample of something, and he could not write his name accurately. It was really, really horrible. What's going on here? And then I started to sense that he couldn't tell the difference between his right from his left. That was another interesting thing. What's going on here? And then also we worked on some basic mathematical concepts, and he could not do like 1 + 1. He couldn't give me an answer to it. So I started to really think like this is, and right away, the grad school classes are popping in my head when I read something like this, and then right away I'm starting to think about it, and I'm going through the whole thing through my head, and then I'm doing the sensory motor eval with him. And part of the sensory motor eval that I do is I look for finger identification. So I'll have the person put their hands out, I'll have them close their eyes, and I'll touch the finger, and they'll tell me, and that's when I realized he was making tons of errors. I'm like, holy cow, I think I know what this is. And it was one of those first times in my career that I hit something that was like one of those classic neuropsych cases. And it turns out the gentleman had what they call Gerstmann Syndrome. And it's an injury or it's a syndrome after a stroke to the right posterior parietal lobe. And that's the four main things: is agraphia, so he couldn't write; acalculia, could not do a basic mathematical computation; he had right-left disorientation, could not tell his right from left; and also the last one, the finger agnosia. Agnosia meaning lack of knowledge or not understanding. And a lot of the people at the rehab center, which is fine, I understand why, they didn't know what was going on with him. And I remember a speech pathologist thought he was dyslexic, and there was no history of that, and there was no reason to explain an acquired dyslexia in this guy after a stroke. So the patient was struggling, and his wife was struggling to understand what was going on. This is weird. And because the area of the brain where these four functions were is the stroke unfortunately obliterated that part of the brain. While this sounds a little morbid, it was comforting to him that I was able to explain to him that this is not going to get better, that you can work on your physical issues that you have since your stroke and other issues, but this specifically will not improve. And then we start to do some therapy, working together on that to sort of help him understand that better. But that was probably the one case where, in my opinion, my neuropsychiaval best directed someone on what their expectations were, what their treatment plan was supposed to be. And he actually visited about a year later, and he told me, he goes, Dr. Z, like you said, none of that ever got better, but he compensates. So his ability to compensate for a lot of those issues improves because he's a smart guy. But all those four things that I mentioned never improved. So while I wish those things got better for him, I knew based on the neuroanatomy, based on my neuropsych testing, which to remind you, the neuropsych test, I almost threw out all the papers because none of those tests were going to really tell me exactly what it was. I was now using the backs of those papers and starting putting putting 1 + 3, see if he can get that. And then I said, well, maybe he can't read the numbers. Well, what if I put 1 dot plus 4 dots and see if he can give me that answer? But it was just the concept was not there anymore for him, So the fact that I was able to do those things to help guide him, that to me felt like that's the job of a neuropsychologist. That's what a neuropsychologist is supposed to do. And again, that's why that sticks out so well, because I told that story several times.
And, it just shows all the components. You had your observations looking that he was appearing to function pretty well. You got his background information showing that there wasn't any mesh problems. He was a great dart player, so he had some better visual skills and motor than I would ever have. And looking at his functioning beforehand, you did the testing, you saw problems. In the testing, you got symptom review. You had the imaging information, so you knew where the stroke actually happened in order to guide you. And you put all that information together in order to figure out what the appropriate diagnosis was.
Yeah. And again, the most important was to, the discharge meeting, it was a little depressing, but at the same time, it was euphoric for him because he knew, and his wife knew. And of course, even well before the discharge, I informed the treatment team, like, this is what's going on. So that also not only changed his thoughts of how his life was going to continue, but also changed the thoughts and trajectory of the therapists, so they can better say, okay, you know what? We have to revamp what we typically would do, because based on Dr. Z's results and what he's telling us, if I do A, B, and C, that's not going to benefit him. Let's change our plan so we can come up with a treatment plan for him that will best help him. And they did that. So there was a perfect situation where the interdisciplinary team came together. And again, in that case, it was through the guidance of the neuropsychologist to sort of lay out, this is what's going on, and this is why this is not going to get better. But other things can get better, but not this.
Yeah. And we don't have time to go through a whole rehab talk, but just briefly wanted to go through, if someone does have a stroke or a brain injury, what is a typical rehab course? Like, how much can they regain? How much time or window do they have in order to improve? Like, what have you seen doing all those years of work in a rehab facility?
That's sort of like the $64,000 question. It's hard, and I've told several families in my years, I'm not trying to be in the game of prediction. I want to use the hard data that I have as a neuropsychologist to best give them an impression of how the person's trajectory is. So every patient is going to be different. I remember one time someone told me, if you've seen one brain injury patient, you've seen one brain injury patient. So it's going to be very different. But however, though, if you look at some of the research, like I mentioned earlier, folks who are aphasic, their initial presentation is aphasia. Those folks tend to improve dramatically. Look at someone like Gabby Giffords, Congresswoman Giffords. She was actually treated here in the Houston area, and she worked with some great speech pathologists, and it was very intensive therapy. And look where she is now. Like, even when she presented, I think recently at the DNC, how well. Now, granted, probably very practiced, but really well. Another celebrity is, look at Bob Woodruff, ABC News anchor, when he experienced an IED explosion, or he was the victim of an IED explosion back in 2004. It took out the left side and damaged the dominant hemisphere. He's still out there advocating and doing news coverage. So again, there is a level of improvement. It really also, the brain is very much like real estate. It's about location, location, location. So depending upon where the injury is could also impact the trajectory and the course of that person's level of improvement. So there's studies out there that will say continued improvement can happen in a person with stroke or brain injury for years after the actual injury. Again, there'll be a course and eventually maybe more of a plateau on how that improvement goes. But again, I can't stress it enough, for a person with that kind of injury to get rehab just really helps push out that improvement wave, and it helps their chances of making as much improvement versus someone who did not get any kind of therapy whatsoever.
Does it matter how quickly they get into rehab after the onset of injury?
That's another one. So after a severe injury or stroke, the person will be in an acute setting, and then they may go into like some sort of subacute setting. The main goal, of course, in those settings is for medical stability. So you're not going to try to engage someone in intensive therapy until they're medically stable. Depending upon that, sometimes, and if there's a lot of behaviors, you may not want to thrust someone into a comprehensive rehab program if there's too many behaviors going on. So they're not attending to the therapy. They're especially if they're a frontal injury, they're going to be impulsive or inappropriate or aggressive. So depending on the case, if it's an aphasic person, I think, and they have hemiparesis, there's some need for physical therapy and occupational therapy. Yes, the sooner the better. If the person is more frontal and there's a lot of other behaviors that may thwart their ability to complete a comprehensive program, it may be better for them to go to some sort of neurobehavioral program first, sometimes to get psychiatry on board to help quell some of those behaviors and emotions so they can get into a more post-acute setting to get the therapy they need.
And you had mentioned, that there could be, recovery quicker in the beginning and kind of plateauing. Is there any time frame that we consider where we would assume a plateau? Is there anything around that?
I think a good indication for most is that first 6 to 9 months. I think you'll see a lot of improvement in the first 6 to 9 months. But again, I don't want to say that it will stop at 6 to 9 months, by no means. But you're going to see a lot of improvement early on once the person is medically stable. And then again, but you have to. I don't want to take away from the fact you're going to have a subset of people that will not get any kind of rehabilitation services versus some that do. So in my opinion, the person that gets the rehabilitation services will have a more steeper or better trajectory in terms of their improvement, and probably more prolonged, because remember, a person may come to a post-acute facility for 3 months, 6 months of therapy. Doesn't mean that once they leave that place, they've graduated. So therapy continues on. So if that person can develop some good compensatory strategies and also, and most importantly, get the family educated, that's going to help really push out their ability to make more improvements in the years to come. So really, it's a combination of things. I try not to give like a specific number, like it will be this. It's hard to do because, again, it goes back to a lot of patients. Every patient is going to be different, not only in the nature of their injury, but their support level, the care, the amount of care they're going to receive. So that's going to, or the amount of resources they have. Some people will not be able to get the kind of doctors and therapists that another person would. So that's also something to consider.
Okay. All right. So if people are interested in checking up on what you're doing, or actually want to get an eval by you, or see if there's any updates, how can they follow you?
Yeah, so I'm on Twitter at DJ Zgaljardic, so you can follow me there. Also, I have a website. It's www.gcneuropsychology.com, and the GC stands for Gulf Coast. My practice is Gulf Coast Neuropsychology. But if you want to learn more about neuropsychology as well, I would advise going to apa.org and then look for Division 40. Division 40 is the clinical neuropsychology division of the APA. If you want to look for a person in your state that is a board certified neuropsychologist, I would recommend going to the AACN.org, and that stands for the American Academy of Clinical Neuropsychology. So there you can look by state and look for board certified individuals or neuropsychologists in your state. Okay.
And any interesting books that you recommend that people check out to learn more about neuropsychology?
I still think Descartes Era by D. Tommaso is just a great book. It came out in '94, and it was just, if you want to really get a good sense of executive dysfunction, that's just a great book. And also just sort of the background and history on how it was viewed hundreds of years ago versus having someone like D. Tommaso really come out there and explain it so well. And it's not D. Tommaso, Damasio, excuse me. And it just, that I would say is a really good book to follow.
Okay, great. So of course I'll put all this stuff in the show notes like I always do. I really appreciate you taking out time in order to come on the show and teach people about neuropsych, the different testing, what you guys look like, and also for the community to know when they're asking, when they're going for a neuropsych eval, or a physician might recommend a neuropsych eval or a school, what is it that they're actually signing up for?
No, it's very important. And again, knowledge is power. So I think really the individual needs to know. They see the psychology at the end of that word, but the neuro part always scares them. Again, one of the first things I tell them, I said, it sounds scary, but it's really not. Again, it's going above and beyond of what maybe a typical psychological evaluation would include. Because again, we want to gather more information on the cognitive skills, but also incorporating psychosocial, psychological, sensory motor, neurological as well.
Okay, sounds great. Thanks for coming on.
All right, Jason. Thanks. Bye-bye.